All right, everyone. We're just going to get started here. So once again, wanted to say thank you to everyone for joining us today. In case you have landed yourself into a Zoom meeting that you weren't expecting to land into, you're joining us tonight for session number 1 of 3 on our medication management of OCD Beyond the Basics. And we're joined today by a panel of guest speakers. We have Dr. Ijaz Hussain, who is a consultant psychiatrist with Fraser Health, and who also works as part of the Urgent Care Response Center. We're joined this evening as well by Dr. Glenn Haley, who's a clinical psychologist with Fraser Health, as well as Angela Tong, who is a clinical pharmacist who works at Timber Creek Tertiary Mental Health and Substance Use Facility. Angela is also a clinical instructor for UBC pharmacy students and is a preceptor for hospital pharmacy residents. She has over 15 years of experience working as a clinical pharmacist, along with more than 10 years experience in specialized psychiatry. Now, we have a jam-packed session for everybody this evening. We've got 60 short minutes to learn all kinds of really great information. So one of the things that the panel has asked is if you have some questions this evening, please feel free to put them into the chat. But all of the questions are going to be held for responses. We've got until the end of the session, we've got a package of time held off for you guys to answer some questions. So if you do have something that one of the speakers is talking about that you'd like them to address in the Q&A period, please feel free to put it in the chat and we will get to that afterwards. Additionally, if you can remember to keep yourselves muted. And most of us kind of know the rules about Zoom calls nowadays, but just in case, if you could remember to do that. And do feel free to put your camera on. It's really great to see all of your lovely faces and maybe give a wave to some of our colleagues together. But certainly don't feel the pressure to have your camera on if you have some Zoom fatigue. That can be very real. Just shortly before I hand over the speaking presentation portion to our speakers, just a couple of two small additional housekeeping items. The first is that because this is a CME, we are going to have a small 2-minute evaluation at the conclusion of the session this evening. You'll see a link posted into the chat box at the end of the session for you to complete your evaluation. And as soon as that's done, by tomorrow or the next day, you'll have your CME certificate emailed out to you. And otherwise, again, please feel free to interact in the chat, ask questions if you need to, say hello to your colleagues. But with that, I'd like to give a warm welcome to our speakers, Dr. Hussain, Dr. Haley, and Angela Tong. Thank you so much for being with us this evening. There we go. You guys should have the PowerPoint up on your side. And Dr. Hussain, I will hand it over to you.
Okay, thank you, Apple. So welcome everyone to the meeting. We have divided the meeting into 3 main portions. One is the brief psychopathology of the obsessive-compulsive disorder, then some psychological treatments, and then the medication management. I will briefly talk about the psychopathology. Dr. Haley, as a psychologist, will talk a bit about the psychological treatments. And then Angela will talk about pharmacological treatments. We have also made some small videos as a part of the presentation, which are a kind of a repetition of what we are going to present. But we thought it will be good as a visual memory to remember the information. The O.C.D, I have kept it to the level that actually, as a family physician, we see a lot of the clients. So I haven't gone to the very complicated level of obsessive-compulsive clients, because that may be a bit more than what we expect from a family physician. But I can briefly answer some of the questions if we have very complicated cases that people want to discuss. I also would like to say that the focus is mostly the obsessive-compulsive disorder. We know that the O.C.D can present as a comorbidity. But I have tried to focus mostly around the obsessive-compulsive disorder in this presentation. So anything that has been mentioned here is specifically focused around O.C.D. If we're seeing comorbid associated mental health issues like depression our anxiety. Of course, they are important to discuss, but in order to be more specific to the presentation, this presentation is specifically about the obsessive compulsive disorder. So April, if you can go to the next slide. So I will briefly talk about the psychopathology of the obsessive compulsive disorder, like how to, we know that people are very comfortable in diagnosing the obsessive compulsive disorder, but if we just know some of the brief background of the obsessive compulsive disorder, it makes it much easier to understand where this originated from. There are DSM-5 criteria and there are ICD-10 criteria, but just some of the main concepts behind the OCD are important to remember. We all know that these are the subjective either thoughts or images which are considered as strange. If they're not considered as strange these by the patient themselves, then these are not the obsessive compulsive disorder. There are three main components to the thought pattern. One is that there's a subjective compulsions. This is to differentiate between some of the rituals that people have related to their ethnic background. So for example, different people do different types of prayers, and they are not considered as obsessive compulsive, though these are repetitive rituals. So that was the basic concept behind it, that there needs to be a subjective compulsion, that they feel like they have to do it. It's not like they want to do it, it's like they have to do it. The second point is that there is a resistance to the whatever thoughts they are getting. If they're not getting the resistance, then basically this is not an OCD. And one of the typical example would be fantasies. Different people have different fantasies, and they sometimes get those thoughts, or they just get into certain rituals based on their fantasies. This is to differentiate between the fantasies and obsessive compulsive disorder. And the third thing is the presence of insight, that they have a full understanding of what has been happening. They understand that these thoughts are their own, as compared to the schizophrenia, where the patients sometimes think that the thoughts are put into their mind by somebody else. Mostly the functioning is preserved, at least in the initial stages of the illness. Once the illness is advanced, it unfortunately can affect the functioning dramatically, but in the initial phases of the OCD, the functioning is preserved. As compared to the schizophrenia, for example, where the functioning is markedly affected, even in the initial phases of the psychosis as well. April, if you can go to the next slide. So some simple terminologies. There is a simple OCD and there is a complicated OCD. Simple OCD is somebody thinking, for example, there are germs on their hands and they are washing their hands. Complicated is where there are multiple ideas mixed up with each other. So this person, for example, has to check the doors multiple times before going to bed. But not only does they have to do it, but they have to wear a special type of pajamas that they want to just check the door, and they have to put their right foot first in front of their while they're getting out of their room. So like there are multiple thoughts, complicated, interlocked with each other. Why it is important? Because the more complicated the OCD is, the more difficult it is to treat. There are different types of obsessional images. So for example, one is obsessional, where there's obsessional thoughts are coming. The other is compulsive, where there's not only obsessional thoughts are coming, but there's an associated compulsive behavior. Then there's a disastrous type of thoughts where people think like something bad is going to happen to them. Mostly the checking rituals, where people are checking, if I don't check the door, maybe somebody will come to my house. Are the disruptive obsessional images, where you may see people who are doing certain functions, but they have to do it in a particular way, like you have to stand on the right side and this person needs to hold the cup of water in their hand, or this person needs to hold the flowers in their hand, and they want to just do one thing multiple times because it's not going according to their obsessional ideas. The rituals are mostly a kind of a pseudo-philosophical thoughts, which are mostly irritating to the person and to the other people who are around them. April, if you can go to the next slide. Obsessions, we need to remember that it's not only obsessive compulsive disorder that we get the obsessions. There are a few other illnesses where you get the obsessions very commonly. So on top of the list would be the depression. people have the depression and they can have the obsession with it. And it typically improves if you treat the depression. In that scenario, you will treat the depression, not the obsessive compulsive disorder. Dementia and other organic states, so head injuries, those kind of things, you will just very typically see people coming up with the obsessive compulsive disorder. We have seen that very commonly in dementia. And lastly, schizophrenia. We know that a lot of the clients who have schizophrenia come up with the obsessional symptoms at the same time. Next slide. So one other thing which I will briefly talk about is the obsessive compulsive personality. Majority of the professionals, I'm not saying every professional person, but majority of the professional among us are having some obsessive compulsive personality, or it's also called as an encaustic personality. Basically, like these are the people who want to get full reassurance that actually nothing will go wrong beyond before they will just take any actions. You may just see these people just having multiple maps and multiple plans and just one thing after the other before they just make any kind of travel plans, for example, and they just check various sites to make sure that they are aware that the weather will be fine, the flights will be perfect, and they will not just miss their bus. So something like that. And these kind of personality, I just briefly mentioned in here, because typically the treatment for obsessive compulsive personality, unfortunately, is not with the medicines. So it is important to just mention it here briefly, but that is the one thing that you may see a lot of the time, and it should be differentiated from the obsessive compulsive disorder, which is slightly different. Then I will go to the next slide, which I will let Dr. Haley to present. This is particularly for the family physician if they want to use it in their setting. It is about the obsessive compulsive scale. So Dr. Haley, up to you.
Well, first I wanted to talk about the anacastic personality that you mentioned. Freud argued that it was somebody who didn't get through the anal phase very well. So that's where it actually originates from. The perfectionistic, the anacastic is kind of anal retentive is where that personality originates from. Just thought I'd throw that out there. Okay, let's get to the scale. The great thing about this scale is that it's really easy to use, well-defined. It gets you a score that you can interpret in terms of its severity, and it is free. You can just download it. It consists of 10 items, and they're divided into two parts. One's covering the obsessive nature, and the other items concern the compulsive parts. The first three items deal with how impaired the person is from their OCD. For example, the first item is how much time do you spend on obsessive thoughts? And the scale ranges from 0 to 4. But the scale has definite meaning. So a 0 would be a no time, and then severe, a score of 4 would be more than 8 times a day spending, or 8 hours a day spending in their obsessive thoughts. And then after that, there's an item on how much resistance you put up. And the next section's on compulsive parts, how much time do you spend performing the compulsive behavior, and so on, all the way down. So you get 10 items, then you can sum them, you get a total score, and then at the bottom of the sheet that I'm looking at, you can get an interpretation, such that if you get a score of 8 to 15, you have mild OCD, 16 to 23 is moderate, and severe, 24 to 31. So if you're thinking about therapies and interventions, then if you're in the moderate range, you might think about, hey, well, this person might need both psychological and maybe some medications. But when you're getting out there like 32 to 40, which is a severe, it might be more starting with a medication intervention. So that's a great thing, the SICK. The other part of it is very reliable and valid. And you don't need a lot of training. You just have to look at the items. They're self-explanatory, and each item has a definite meaning to it. So even if you're looking at individual items and you're looking across time, is my patient changing? Are they getting better? You can look at how they change across time from just the individual item, not only the total score. You can say, oh, he's getting out of the severe range, he's into the moderate range now. That's good. But I can also look at individual items and see if they're improving on the particular areas they were having a lot of trouble with. And that's basically it. You can go to the next.
Okay. Thank you, Dr. Haley. Dr. Haley works with us as a psychologist at Timber Creek, which is a chronic care facility. Dr. Haley, can you just briefly tell us a bit about the this Yale-Brown obsessive-compulsive scale? Just as a family physician, what should I know about it?
Okay, yes, the first thing is that it's easily accessible. You don't have to hunt around for it. It's available. You can download it online, and there's no charge. The second thing is that it is a valid and reliable item, a scale. So you can be confident that whatever you're getting on is going to be meaningful and reflect the severity of O.C.D. So there are 10 items. The first 5 items deal with obsessions, and it tells you what they are at the top: frequent, unwelcome, and intrusive thoughts. And they're rated on a 4-point scale, so usually from mild all the way up to very severe. And each item has, each scale item has a definition. So you don't have to say, what does a 2 mean? It tells you what a 2 means. So a 2 might mean I try much of the time to resist my obsessions. Or it could mean that I spend up to an hour a day or more. A very high rating would be more than 8 hours a day I spend thinking and having obsessions. So there are 5 of those items. There are 5 for the compulsions, and they define the compulsions: repetitive behaviors or mental acts that you have a strong urge to repeat and that are aimed at reducing the anxiety, because the obsessions produce anxiety, and these are the things you try to do to reduce the anxiety. Again, they're all rated on a 4-point scale. And the thing is, you don't need a lot of training. Or you just need to look it over, and because, as I said, the items, the scale items have a definition. So it doesn't require kind of a lot of training. Or you just look at it, try it out, use it. The good thing is, it gives you a good and reliable relating of the severity. So when somebody's coming into you, you give it to them and say, oh, it's mild, you can figure out what to do. Usually, though, they're going to be coming in at a moderate level. So what is a moderate level? You add up all the items, and you get a score, and then you look down at the bottom of the page, it tells you what category the score represents: mild, moderate, severe, or extreme. So it gives you a good idea of what kind of treatment am I going to start with. If it's mild or moderate, you might think about some psychological treatments that we'll talk about. Or if it's very severe, you might think about some kind of medication or intervention at the start. And the other part of that is you get an idea if it's working. So they can come in, you ask them the questions, and you find out whether or not it's working and they're improving. So it has that part built into it. So from that vantage point, it's very useful. And you're not just kind of guessing, and you're not, well, you've got them rating it. And oh yeah, you, the interviewer, you can use it as an interview rating scale. There is a self version, but usually you would do it yourself.
Thank you, Dr. Lee. Okay. So probably if we can go back to the presentation now.
One second. I'm just moving it over. There you go.
So I will briefly talk about the treatment focus. So the first thing is that it's a step care approach. What it means is that you start from the lowest possible effective treatment and then go up stepwise. It's not like that you just go on a very high end to start with. Make sure that the assessment is focused around functional impairment and comorbid conditions. If there's a stress, functional impairment, and if there's a comorbid condition, we need to just focus on that. Primary disorder should be treated first. As I mentioned, if there's a schizophrenia and OCD, then schizophrenia should be treated first. If there is a dementia, then dementia should be treated first rather than treating the OCDs first. Psychological therapies are considered as the first line. So that is the important thing, that all the guidelines that we have reviewed, actually psychological therapies are the first line, in particularly in the mild to moderate. In severe cases, you can go for the medicines first, but for all the mild to moderate, it's a psychological therapy. Pharmacological therapies are effective, particularly SSRIs. Augmentation strategies should be considered if response is suboptimal, and patient personal choice is also very important, and combination therapy might be beneficial in refractory and complex cases. NICE guidelines are basically the British guidelines. CanMed guidelines are the Canadian guidelines, but the overall recommendations are the same. There's no difference between the two, so I have just put them together. In the initial treatment phases, it's important that we focus mostly on the cognitive behavior approaches, mostly the exposure and response prevention. It could be that you can provide them the written information and let the client just basically help themselves if it is a mild case. Or you can just also refer them to the group treatment program, but the main focus needs to be the exposure and response prevention, which has an evidence base. Next slide. If it is a mild functional impairment, then you could just mostly focus on the SSRIs or just the CBT. If it is moderate functional impairment, then you can start with the SSRIs, or you can just go to the exposure and response prevention. But this time you need to focus on the time. The more time that the therapist spend with the client, the better results you get. So as much distress is there, the treatment needs to be accordingly. So for example, at Surrey Mental Health, we just typically provide them 12 hours of session, which is recommended time for moderate to severe functional disability related to the OCD. Anything less than that should be considered for mild cases, but when there is a moderate to severe, you need at least 10 hours of therapeutic time with a client while using the exposure and response prevention treatment. Next. So I will start with this psychological treatment. The first thing as a family physician is the supportive therapy. And I just give you a very interesting example of from my personal life. I remember that once I would say about maybe 20 years ago, I went with my dad to my family physician. And at that time, we had only paper files. There was no EMR. So he was looking at my file, and on two occasions, he just basically said, "Oh my God." And I definitely felt like he's going to tell me that I have some kind of a cancer or some kind of a really bad results. And so I just very anxiously asked him, like, "Is everything okay?" And he said, oh my God, I just forgot my glasses at home. I couldn't read it properly. So I was just only trying to say, "Oh my God," for that reason. So I think that is exactly what happens in the OCD. The clients come to you, they're highly anxious. They basically feel like you're going to inform the police on them, you're going to inform the MCFD, or you're going to lock them up. Or, for example, you're going to tell them that how stupid they are, or you're just going to tell them that they are schizophrenic. So I think the first thing is that as a family physician, the supportive therapy is the most important thing. We need to make sure that the clients are encouraged to tell you the whole story. They typically feel very comfortable in telling you that they are washing their hands multiple times because they think that there are germs in there, but they are very uncomfortable in telling you that they have thoughts, for example, that they're going to touch somebody, their children inappropriately, and they're very disturbed by it. They're not going to tell you, so you may have to dig out those of the informations because clients are highly anxious, and that will be considered as a therapeutic procedure for them. So if you can go to the next slide, which is a video, and April, if you can just show that video quickly.
Yep, Just loading it up for you right now.
So here we are to discuss a bit about the obsessive-compulsive disorder. Tina McDonald works as a nurse with the mental health services who have provided care to the clients who suffer from obsessive-compulsive disorder. So Tina, we are going to briefly discuss that if we are providing a care to the client in a family physician office who do not have enough time to just do the therapy, besides prescribing medicines, is there anything that as a family physician they can do to help their clients who are struggling with obsessive compulsive disorder?
Yeah, I think the most important thing is giving them reassurance, providing psychoeducation, but giving them a safe space for them to provide the symptoms. They maybe feel guilty or feel ashamed of their feelings, their thoughts, and are scared. Making them feel comfortable and reassured that they can share that so that they can get the proper care.
Is it like they have certain types of symptoms, for example?
Yeah, unusual thoughts that they might find scary and that they're worried that they're going to act upon.
I have a patient who was just scared that they had these obsessive thoughts that they may inappropriately touch people, and they were scared that their family physician is going to inform the MCFD. So in that kind of situation, do you think that the family physicians are going to inform the MCFD, or is there a risk?
No, I don't think that there's a risk for MCD involvement. There's no need.
Okay. What about any other things that a family physician can do for their clients beside this?
Just reassurance. A lot of the clients, it would be scary, these thoughts for them to share, and they're feeling guilty for having the thoughts, the feelings. Maybe reassurance that they don't have a severe illness like schizophrenia, that they think that's what they have, rather than there is treatment for O.C.D, and that they just need to be reassured that is the scary thoughts.
And do these patients get better?
Yes, they do. They do get better with
So
treatment.
like just telling them that they're going to get better.
Yeah, and it probably helps them for them to be free to express that they're, instead of hiding away and just going home and concerned and really not sharing with the doctor what is going on.
And are there any services that can be mentioned to these clients in case if they're living in Surrey area? Is there any particular place they can
there's
go
the
to?
UCRC, which is on the Surrey property, and it's open between 8:30 and 8:30 Monday through Friday.
Thank you, Tina. Appreciate that. So next would be the exposure and response prevention. So I will let Dr. Haley explain that, please.
Okay, right. So we'll have a video as well. But the basic premise of the treatment, it comes from behavioral models of conditioning, where there's the obsessions or conditioned responses. And the idea is for the exposure is to habituate them to the fears, such that the anxiety disappears and they become deconditioned or habituate. Cognitive models take a little different approach, and I'll talk about that a little later. Basically, you have the obsession that generates the anxiety. The compulsions or rituals then are needed to reduce the anxiety. And because the anxiety is reduced, it then reinforces a ritual, so you kind of get stuck in there. So the idea of the therapy then is to prevent them from doing the rituals such that they're exposed to the fear long enough that they realize it's not going to harm them. And that's easier said than done. But that's basically the model. So you got to prevent them from doing the ritual, and then they have the fear and keeps going and going, and they tolerate it, and it becomes less of a problem. I think the other thing I don't think I talked about in this YouTube link was the cognitive model. So maybe I can talk a little bit about that after this. We can go to the link.
So, Dr. Haley, in majority of the new guidelines, exposure and response prevention is now considered to be the first line treatment for mild to moderate cases of obsessive compulsive disorder. What does this mean, exposure and response prevention?
Yes, the exposure part means that the patient is going to be exposed to the thing they fear. And the thing they fear is usually obsession. So they have the thoughts, the images, the repeating words or phrases. And you're going to expose them to that image. The anxiety that's generated then is endured, because response prevention part is that you're not going to let them engage in the kind of avoidance or the kind of rituals that they used to neutralize that anxiety. So you've got the exposure to it, the anxiety comes up, and you say, well, you're not going to engage in the kind of behaviors that you've been using all this time. And that's basically it. It's kind of like a phobic response. You're going to be in the situation long enough to realize that those thoughts and images aren't going to harm you.
So, for example, if a woman comes to me in a primary care setting and says that she has this obsessions that she may harm her children, and she gets this image of stabbing her child with a knife or something, how can I use this technique, or what should I tell this patient that will be in the lines of exposure and response prevention?
Yeah, the model still works, even though it doesn't seem to be very clear what the compulsions are, or what the rituals are. It's the same idea. So they have the obsession, which is this image of harming their children, and then that generates the anxiety. But what is it that's reducing that anxiety? So we just find out what it is that they're doing, what kind of avoidance strategy, or what kind of behaviors they're using to neutralize it. So you find out, well, she might figure that she spends a lot of time doing something else. Like, I spend a lot of time cleaning, I spend a lot of time doing my music, I go and I put my headphones on, and I'm doing a lot of things which you might think, well, it seems to be reasonable, but it's an avoidance strategy, because the idea is to tackle head on the image. So you want to expose her to the image, not let it go, because if you replace it, so what I do is I think about this and then I replace it with a nice pleasant image. No, that's avoidant. So you must have that image there, and you're going to work on it. Tell me about that image, give me those details, and keep that anxiety up. So the idea is, once the anxiety's up, get the details, draw a picture, do a lot of that kind of work, so that the anxiety starts to habituate to that image, and it starts to diminish. So she calls you and says, look, I've got this image, what am I going to do, doc? And you said, well, the chances of that happening are so low. She goes, oh, thank God. That does not work, because it's just reinforcing now. I've got my anxiety down a notch. So the idea is always these behaviors that you do, avoidance behaviors, are being reinforced because of the anxieties coming down. And get that idea so that when you are in the situation where you're exposed to the anxieties, up, but nothing bad is going to happen. And that's sort of the basic feature of the exposure and response prevention.
Okay. Thank you, Dr. Haley.
Let me see if am I on? I am on. Yeah. So a couple of things on the cognitive therapy takes a few extra steps in there.
At Mark's, we're here for all your fall walks.
Walking all day with my mind.
I don't know what that was.
Brother,
So-
if you can go to the next slide, please.
Yeah. Oh yeah, so the cognitive therapy. So in cognitive therapy, we want to look at what the appraisal is. So there's a cognitive appraisal of what's going on. You have this image in your mind, and you trying to figure out what is the connection. So oftentimes your patient's going to say, you know, just thinking about it is the same as doing it. There's no distinction between the thought and the action. Or if I don't do the compulsion, that means it's going to happen or I'm going to do it. So there's that appraisal that, look, I keep thinking about harming my children. And when I do my ritual, it goes away. So that must mean that it's going to happen. And I'm I'm a bad person. And you kind of look at what is the appraisal, and you're going to challenge the belief as well. It's not just exposure, but you're taking into consideration what are the negative thoughts that go along with it. And the negative thoughts, they come automatic. There's no thinking about it. So they're coming in, and you're going to get the person to think about what it is, or write down what is the thought. So is it really true that just because you think about it, it's going to happen? And then you say, what is the probability it's going to happen? What are some other ways of looking at this? And like in regular cognitive therapy, generate some alternative hypothesis and try to say which is more likely. So kind of breaking out, which is more likely. And you do a lot of homework exercises and a lot of work to get on that. To take a slightly different approach. So it's not so much habituation as you're trying to build in tolerance, and then you're not trying to get the anxiety completely removed. You're just going to have it there a little bit because you're going to have anxiety. You're just going to have to tolerate it and realize that, yeah, this anxiety does not mean my thought about harming somebody or my kids is true. And that's the cognitive. Yeah.
Yeah, I think the main thing is that you need to make sure that the client need to be cognitively quite intelligent and understand these concepts. Yeah, so this is the full CBT model. Can you just go to the next slide?
We have the worksheet here.
Yeah, so the worksheet is there.
Yeah, all these cognitive models have the worksheet. As I said, it's a way of tracking and writing things down, so that just the act of doing that gives them some separation and a little bit of objectivity. And what I tend to assume is like, yes, what I think is real, or it's going to happen if I don't do my ritual. And then you look at what the results are, and then you generate, get them to rate how anxious they are when they have that thought. And then if you come up with an alternative thought, then you're going to see if that helps reduce the anxiety. Now, just telling them something like that isn't going to work, so they have to do enough homework to be able to believe that alternative, that if I don't do the ritual, yes, I'm going to harm somebody. So if you just try some kind of techniques to reduce that, like you might just have imagination steps, tiny steps that reduce anxiety, and basically try to show the person that it's not going to harm you. Yeah. So that's very helpful to have that. That's basically homework is built into the CBT approach. And it can be it's very effective. It's the exposure part is still there, but you also have the appraisal part, and that's important as well. Okay, we can go on.
Yeah, no problem. So I think the next steps are the pharmacological treatment, and I will let Angela just go through that.
So basically, for pharmacologic treatment, we should be using evidence-based treatment. The gold standard are SSRIs and clomipamine. We should always consider using SSRI as first-line pharmacologic treatment because it's easier to tolerate than clomipamine. And you should consider increase the daily dosage of SSRI if the patient is not showing sufficient response at a lower dose. And advise the patient that the initial treatment period beyond 6 weeks will be needed to assess the true efficacy of the medication. And in terms of long-term treatment, the drug therapy should be consistent and continue for at least 12 months in patients who have responded to the treatment originally. And throughout the drug therapy, it's important to monitor for efficacy and acceptability to check for side effects over the course of the treatment. And one should consider combining an SSRI or clomipramine with an evidence-based psychological treatment, which is the exposure therapy or the CBT, when efficacy needs to be maximized. In terms of indefinite treatment, is mainly for patients who have very severe OCD symptoms or refractory OCD symptoms, then they should be on indefinite treatment. So when initial treatment fails, you should consider increasing the dosage if the current dosage is well tolerated for that specific medication. Or you can switch to another evidence-based treatment. For SSRI, there are a few medication that has evidence, such as the paroxetine, fluoxetine, citalopram, sertraline. So you may want to switch from one to the other if one does not work. And also adding the CBT or ERP2 medication will be more effective for patients that do not have full response. And in other situation, when you have already optimized the SSRI medication in conjunction with psychological treatment, you may consider adding an augmentation, such as an antipsychotic, which is usually atypical antipsychotic, risperidone or aripiprazole. They have some evidence in using as an augmentation strategy, but also to keep into consideration that when there is no contraindication for those antipsychotics. Next slide.
So thank you, Angela, for being interviewed today. Angela works as a pharmacist with us in Timber Creek, which is a chronic care facility in Surrey. So Angela, I have a few specific questions in relation to obsessive compulsive disorder. And we're not talking about any comorbidities, specifically only obsessive compulsive disorder. What are the first line treatments from pharmacological perspective in obsessive compulsive disorder?
First line treatment are SSRIs. The medication that have evidence include fluoxetine, paroxetine, sertraline, citalopram.
Okay. And what kind of medicines that we typically use in other anxiety disorders and mood disorders, which have no evidence base in OCD, so that we don't prescribe it for the clients who have obsessive compulsive disorder?
Yeah. The only medication that have evidence from the TCA is clomipramine, which is the second line for OCD. The other TCA has no evidence, and lithium, ECT, clonidine, risperidone all have no evidence.
What about benzodiazepines?
They don't have any role in OCD.
Any role for ECT?
ECT, no.
Okay, and lithium?
Yeah, no.
No role for that. Okay. Then there is this concept that we need to use higher doses in obsessive compulsive disorder. So what is your understanding that is it must for the client to go on a higher dose when they have the diagnosis of obsessive compulsive disorder?
This is a controversy issues. From the studies, it shows that fluoxetine up to 40 milligram a day is beneficial for patients, but there is no specific recommendation for individual SSI. What is the maximum dose recommended? It's really based on the tolerability issue for the patient. If the patient can tolerate a higher dose, then you can go slightly higher than the recommend usual dose for the SSRI. But if they start developing symptoms such as sweatings, diarrhea, tachycardia, high blood pressure, and muscle stiffness, then you need to cut down those to your because the more side effect they experience, they are less likely to take medication.
As a family physician, what are the main things that I need to look at if I'm prescribing clients SSRIs at a higher doses? What are the things that I should be careful about?
Yeah, like the serotonin syndrome that I mentioned about, and also sometimes SSRI may reduce sodium levels, so you may want to check the electrolytes when you're starting on someone with an SSRI. And then specifically, escitalopram have a higher risk of KDC prolongation, so ECG may be beneficial.
If I am treating a client with SSRIs and they are not responding or they start having side effects, so when is the time to think about augmentation strategies? And what treatment has the most evidence?
Yeah, like sexual dysfunction, I think mentioned earlier, is also a very common side effect of SSRI. So if the patient cannot tolerate any of these side effects, or if they have a cardiac history, which clomipramine may not be the most ideal medication to use, then we can use the lowest, the highest tolerable dose for the SSRI, and then add an augmenting agent, which is an atypical antipsychotic. The ones that have evidence are aripiprazole and risperidone.
Thank you, Angela, for this. Appreciate your help.
Thank you.
So this slide basically talk about what type of medication are effective for OCD treatment. All the TCA are not effective except clomipramine, lithium, ECT, MOA inhibitors, benzodiazepine, and bisphenol all do not have any evidence for OCD. Medication which are effective but not licensed for OCD include atypical antipsychotic, aripiprazole, and risperidone. Next slide.
I can briefly go through this. So this is, we are not asking people to answer, but I will just give you a kind of some time to think about it. So this is the case of a 32-year-old teacher who gets panic attacks whenever he leaves the house, as he has to check the door for 30 minutes. He avoids leaving his house until it is really important for him to leave the house, because he worries that he's going to leave one of the door open. As mentioned, once a month he gets the panic attack, and he tries his best to resist the checking the doors. This habit, he's not really happy with that, but he is just getting it. So the question is that, is it OCD, is it panic disorder, or is it agoraphobia, or is it all of the above? I'm not going to ask you to answer it. I'm just going to give the answers. Theoretically, it is all of the above, basically, because he's not leaving the house. He is getting panic symptoms, as well as he has the OCD. The reason why I wanted to give this slide is that majority of these clients come in a combination of these symptoms. So anxiety comes in different forms, as panic disorder or agoraphobia or OCD. So it is very common to just see that in that kind of a picture. Next slide. So the next question is that what is not an appropriate treatment for this client? I will just quickly go through that myself with you. So escitalopram 5 milligram daily, is it an appropriate treatment? Venlafaxine 75 milligram, is it a reasonable treatment? Bupropion 150 milligram, is it a valid treatment? And vertioxetin 5 milligram, is it a valid treatment, or is it a evidence-based treatment? Actually, the word should be the evidence-based. So escitalopram is evidence-based treatment. Venlafaxine is an evidence-based treatment. Bupropion is not an evidence-based treatment. And vertioxetin is not an evidence-based treatment. It may eventually become an evidence-based treatment, but at the moment, it's not an evidence-based treatment. So far, it's only the top two which are evidence-based. Next slide. Okay, so the patient asks these questions, and we will just basically answer these one by one, and I will let Angela continue with it, but I will quickly go through the questions. The first question is patient is going to ask, am I going to get worse before I get better? Very common question that the patient will ask you if you're prescribing the SSRIs. The second question is that they're saying, well, am I going to get addicted to this medicine if you prescribe me? Third is that, what about if I stop these medicines, am I going to get the withdrawal effects? And the last is that they ask, I'm not interested in taking the higher doses because I don't think I'm that sick. So these four questions typically are asked from the family physician. And so how to approach and how to answer these questions. We can go to the next slide, and Angela, you can take over.
This graph shows is extracted from the meta-analysis in 2010. It studied the dose-response relationship of SSRI in OCD. It studied 9 studies. It included 9 studies involving 2,268 subjects. All the studies are randomized, double-blind, placebo-controlled trial. They compared multiple fixed doses of SSRI to each other and placebo in the treatment of OCD in adults. In this meta-analysis, they look at the 3 outcomes. One is the change in the YBOCS score. Second, they look at the proportion of treatment responder in the study. And third, they look at the dropout rates related to all cause or secondary to side effects profile. So this graph shows that the higher doses of SSRI compared to lower or medium doses were associated with improved treatment efficacy when they're using the YBOCS score or the proportion of treatment responder as an outcome. Next slide. This graph has also come from the same meta-analysis from 2010. It shows that the doses of SSRI was not associated with number of all-cause dropout, but higher doses of SSRI was associated with a significantly higher proportion of dropout due to side effects. So the higher the dose is more likely to cause side effect and which causes dropout. Next slide.
I can briefly talk about it on the next slide. So the discontinuation and relapse. So this study, which was done in 2007, very clearly indicates that the dropouts in 24 weeks period, it is almost double if you stop the medicine. The relapse rate is almost double as compared to if you continue the treatment. In other words, it indicates that the longer a treatment is more beneficial if you are on medicines. Next slide. This is a bit of a controversial study, but it is specifically for the clients where we are using unlicensed doses. So this one particular study, which was in 2006, they got 66 treatment-resistant clients who were already on equivalent of sertraline 200 milligrams dose. And they just basically randomized them into 2 groups, and they increased this dose of medicines to, for example, 250 to 400 milligram of sertraline equivalent. But it was not placebo controlled. So it was like the client had 200 milligrams, and next day they got, like they had 2 tablets, suddenly they got 3 tablets. But the control group only had two tablets, so there was no placebo given to those clients. So they noticed that there was an improvement in the symptoms with no increased side effects. But there has been a lot of criticism about it, that it was not placebo controlled. So as a result, just client may have a placebo effect, that they had more tablets, so probably they just started feeling better. But that is the one study of its kind where they just noticed that if you increase the dose, then probably clients can start feeling better with that. Next.
Now I'm going to talk about the activation syndrome. What it means is when you're initiating SSRI or clomipamine, patient will experience some side effects which should be temporary in the initial phase. They include insomnia, increased irritability, increased impulsivity. They may become anxious, having sweating and diarrhea. They may be more agitated, have some akathisia, or they can have hypersomnia and increased hostility. Next phase. Next. For a patient that has been on SSRI for at least a couple months or a year, if they have to stop the medication, they should taper the medication off gradually over several months, because if you stop them abruptly, it can lead to discontinuation syndrome, which can be very uncomfortable for the patient. They may experience anxiety, insomnia, crying spells, like tremors, fatigue, lethargy. Basically, they would have like a shock feelings. So in order to mitigate this problem, if you're finding that if you're reducing the dose too quickly, they may experience the withdrawal effect. So you may want to go back to the previous tolerable dose and then reduce the dose even slower. So some patient may be more sensitive to the medication withdrawal. So you just have to work with the patient. If discontinuing the medication is a goal, yeah. Next slide. Some physician may ask that, or some patient may ask if there is any addiction to SSRI. Basically, there is no cravings involved and there is no street value, so there is no risk for addiction. You can assure the patient that there is no risk for addiction. Next slide. In terms of risk, the only thing with cardiac risk would be the major risk for QTc prolongation. It's mainly the citalopram and escitalopram. For TCA, the clomipamine has a lot of cardiac side effects, so that's why it's a second line in terms of pharmacotherapy. For a patient that had a history of cardiac events or MI, sertraline would be the drug of choice for these patients. For SSRI, there's another risk. There may be hyponatremia, so it may be a good idea to check the electrolyte for your patient when you're starting the patient on an SSRI, especially for older age female, or if the patient had a major surgery, they should also be checking the sodium level as well. Sexual dysfunction, it's very common for a patient who is on SSRI. After you have ruled out other possible causes of erectile dysfunction, you should really work with the patient to find a solution for the sexual dysfunction. Basically, waiting for spontaneous remission is not effective, and drug holidays is also not effective. You can consider dose reduction of this SSRI if the remission of OCD is achieved. Sometimes you can add a aripiprazole as an augmentation strategy to mitigate the sexual dysfunction. And some patients may need maybe erectile dysfunction medication to help to alleviate the side effect if they want to stay on the medication.
So I will just
okay.
Yeah, so I can just briefly summarize. So CBT, once again, is the first line for mild to moderate. SSRI is the first line where the medicines are required. In severe cases, start with both CBT and SSRIs. Increased dose were required and tolerated. 6 weeks is the minimal time to wait for the response, which is slightly different than the depression, where even in 2 weeks you may get the response, but here you have to wait a bit longer. If one treatment is effective, then change to a different evidence-based treatment or combine it with the CBT or escitalopram plus clomipramine. And if it is effective, then 1 to 2 years time is required in majority of the cases, or can be indefinite depending on the nature of the symptoms. Next slide. So these are some of the resources. I didn't particularly mention about two things, which I will just briefly say. One is that the mindfulness has some evidence to improving the OCD. Similarly, the RTMS is growing some evidence to it, but still it is not enough to just basically consider that as a evidence-based treatment, but there is some evidence growing in terms of RTMS that it might be effective in OCD. And we also know that there is a psychosurgery which is available to the BC neuropsychiatry program, but theoretically you need to have a local mental health team involved for that. These are some of the clinical resources for patients. So there is an international OCD foundation, and then there is psychoeducation to the patients. Similarly, OCD managing at home on your own, and National Institute of Mental Health OCD flyers for our clients. So some of those resources I have included in it. And that is it. It took longer than what we expected. So I will just quickly go through some of the questions that have been mentioned here. What is the incidence of sexual dysfunction as side effects with citalopram, escitalopram? Angela, if you have anything to say, otherwise I can answer it.
I don't have the percentage on top of my head. Do you have the percentage?
Yeah, so simple way is that simply remember it's 1/3. So you could say it's about 33%, but it is very common, in other words. That is the simple thing to just remember it. And it is important to just basically ask this question. So it is not uncommon, it is common. And as you go up on the dose, the chances keep on getting higher. So even at the lower doses, it's about 1/3. As you keep on going up on the dose, then it gets higher. When would be the ideal time to check the sodium levels when initiating SSRI treatment? Also, is there any value in regular monitoring for those on long-term therapy? Angela, anything you want to say?
I think it's also dose related. So I think it will be best to check maybe in a month time, like maybe earlier if patient had a higher risk factor, if they're taking other medication that may also reduce the sodium level, or if the patient has a concurrent illness that may cause them to drink more water, like such as psychogenic polydipsia. If they're drinking, like have a tendency to drink a lot of water, then you may dilute the sodium. So you also look at the risk factor of the particular patient. In terms of regular monitoring for long-term therapy, if the patient has been stable on the medication and without any issues, usually I don't see any necessary need for continue checking the sodium level. I will only be maybe more mindful for the patient that already have a drop in the sodium. Then those are maybe the patient that you may need to monitor more frequently, and then also the patient that who are on like maybe like a diuretic that may cause a low sodium, then those would be the patient that you should be watching out for.
And I think one thing which we mentioned is the major thing from the family physician perspective. If your patient is going for some kind of a major surgery, just remember it is one of the very significant factor that causes a drop in your sodium level. So that is something worth considering. The next question is that what is the best SSRI in terms of erectile dysfunction as side effect? Angela, if you want to say something about it.
The only antipsychotic, I mean antidepressant that does not cause erectile dysfunction is the bupropion. Unfortunately, bupropion has no evidence in the treatment of OCD, and SSRI in general they are pretty similar, I would say, unless like Dr. Hussain, you have any things to add.
Yeah, so I think not related to the OCD, but vortioxetine is considered to be the choice if you are just really stuck with the SSRIs. The other thing which we normally do is that you just try few and you see which one is best tolerated by the patient. But if you're saying that which one is the best, there is no such thing as the best in terms of the OCD. Unfortunately, vortioxetine is still not licensed or evidence-based for the OCD. So you have to try a few and you may find that one is causing less of that problem for the patient. But unfortunately, they all have this side effect.
If there are other questions, please feel free to put them in the chat, and certainly we can continue to respond to them. In the meantime, there is a link in the chat as well for the evaluation. It should only take you a minute or two. There are two links right now. The first one, some people were having some difficulties with, so you could try the other one as well. It should only take you a minute or two, but while you guys are doing that, I just want to extend a very grateful sense of thanks and gratitude to Dr. Hussain, Dr. Haley, and Angela Tong for joining us this evening. It was a very valuable session and a lot of great insights and a lot of great tips, and lots of learning opportunities. So we're really grateful for your time this evening. Once everyone has finished the evaluation, please feel free to drop off. We appreciate your time this evening and spending a little bit of your evening with us, but we won't hold you captive any longer than necessary. So thanks again for your time, everyone. And we look forward to seeing you at our next session next month. Thanks so much.